guest tonight. And we are so thrilled. This actually happened very organically to get Dr. Christensen on. Dr. Scott Province had seen his webinar on sleep group solutions and bragged about you to me. So then I was watching, and then Dr. Boyd happened to see him. And then the rest is history. We got you on. But let me tell a little bit about Dr. Christensen's background. And tonight we have an exciting evening because we're going to be reviewing pediatric expansion cases and why the rhinometer and the pharyngometer has become basically a must-have tool for diagnostics and also successful consultations. So I'm going to go ahead and give you a formal introduction, and then we'll have a more casual type of exchange. Dr. Christensen attended Creighton University School of Dentistry in 1993, graduating third in his class. He completed his AEGD U.S. Army Dental Corps at Fort Carson, Colorado, 1993 to 1994. There he received specialized training in oral surgery, periodontics, endodontics, and orthodontics. From 1993 to 1997, he served as a general dentist at the Landstuhl Regional Medical Center in Landstuhl, Germany. He also served as the executive officer of the 464th Medical Company during Operation Joint Endeavor in the Bosnia conflict. 1997 through 1999, he did his orthodontic residency at the University of Louisville, Kentucky, receiving a specialty certificate in orthodontics and master's degree in oral biology with his thesis, Treating Class 3 Malocclusions in Children with Expansion and Face Mask Protraction. 1999 to 2001, he served as Chief of Orthodontics at the Fort Bragg Bravo program. From 2001 to present, he has practiced in Lewiston, Grangeville, Orofino, and Moscow. In the last 10 years, his orthodontic practice has incorporated sleep medicine as a driving force in treating patients in a more comprehensive, health-focused way. In May 2019, Dr. Christensen received diplomate status with the ASBA and became the first orthodontist in Idaho to become board certified in sleep medicine. So welcome and congratulations on quite a CV there. I know that was the short version. So why don't you just tell us a little bit about yourself, Dr. Christensen, and your journey and how you can help us tonight.
All right. Well, hopefully the mail thing doesn't keep popping up here. You don't see that, right?
No, we don't see it. Don't worry.
Okay, good. All right. Well, I think I'm going to just kind of jump into this because my slides kind of bring me along that route.
Go ahead. You got the floor.
All right. So you've already done that. Let me go back to here. My wife said you need to show this picture because all that stuff that you talked about happened years ago. It seems like another lifetime ago. And since moving to Lewiston, we had 6 kids. We have 3 daughters that are married. We have 8 grandkids. And like you said, all of those other things seem like they were just, a whole lifetime ago. We do have a couple of kids that are already in heaven. And so there we go. This is my wife of 34 years. That makes me feel old too. And then here's a whole bunch of the stuff. I'm actually grew up on a ranch in southern Idaho, and I couldn't get away from that. I have a little ranch here. I also have a trucking company. I also have a hay company. And I think I probably have ADHD with everything that I do. I've done orthodontics on the back of a pickup. And a few years ago, actually 9 years ago yesterday, I had a massive heart attack. And I was not supposed to live, and we'll talk about that. But since then, my journey has been to be a whole lot healthier. And I've completed 2 half Ironmans and a full Ironman and a bunch of 200-mile bike races. And then COVID hit. And now I got to get back to it. So not one to sit around and wait for something to happen. If I'm not doing orthodontics, I'm doing many other different things. And so I'm gonna jump right into this, and I'm gonna show everybody some videos. And these videos, I won't even talk through them. I'm just going to show you, and then we'll talk about them. But it's the reason why I'm here, and the reason why I do what I do. So here goes. That's pre-treatment. Let's see here. Let me get to I need to get to the next slide here. Okay, this is 1 week into treatment. Let's see. Okay. This is 2 weeks into treatment. Starting to breathe through her nose. Okay. Let's see here. I think that was, there we go. Here's 4 weeks into treatment. Mouth completely closed. Breathing through her nose. So, let me get to the next one. That's what motivates me, is helping these little kids to be able to breathe. When I put this up here, it says, you know, what do we know, and what were we taught versus what did we learn? Things are different today than what I was taught back in orthodontic school. And then what do we think we know? And going back 9 years ago, yesterday, I had a massive heart attack. And then when I had that heart attack, 60% of my heart was damaged, and my valves were damaged. And the cardiologist said, you're going to have your valves replaced in your heart at some point in time in your life. And that means they're going to have to crack your chest open, go in there, cut your heart open, stop your heart, replace these guys, and sew you back up. And he says, and that's if you make it. Most people that have the type of heart attack that you have, which is a widowmaker, they don't last over 2 years. And so the fact that I made it 9 years is pretty exciting. This last year, I went in and got my CDL and my medical card from driving trucks. And they said, you have a really bad murmur. You need to go get this checked out. And I said, well, yeah, I know. They told me about it. And so I was totally expecting to have open heart surgery. And when I went to the cardiologist, he said, actually, we don't actually stop people's hearts and cut their chest open anymore. We go up through the femoral artery. We take this little transcatheter aortic valve replacement thing, put it in there, put a balloon in it, blow it up, and you walk out of the hospital the same day. It's not even it's an outpatient procedure. And you might say, why am I talking about this? Because when I was taught in orthodontics, they said you can't grow adult jaws, and everything was, how do you say it? I'm going to call it old school. And the stuff that I do now is not from what I was taught in school, but what I observed from my patients, and I changed. And so I do things totally different than I did back in the day. I don't ever take out teeth on patients. And almost every patient that comes through the door gets some type of expansion. And so I think a lot of this terminology that we look at, I think everybody knows these things, what PSGs are, OSA and everything. And a lot of what has come to light is the tethered oral tissues, tongue ties, and the effects of that on the airways and the breathing. And so we'll get into the rhinometry and pharyngometry and how I use that as more of a, it's my report card. When I look at patients, it's one thing for them to tell me, yeah, I feel better and I'm doing better, but I want to have data. I want to have statistics. I want to have things that say, yeah, this is how much you change things, not just, you know, the feel goods kind of stuff. And so there's a whole lot of things that are going on here. When I look at when I was just an orthodontist straightening teeth, it was me, and I was my own island. I was the only person that I dealt with. You know, I would have dentists refer patients to me, but I just straightened teeth. And now when you jump into sleep medicine, we have so many people that are on the team. And now I feel like, rather than me being my own island, I feel like I've got so many other people that are helping me with these patients. And these are just a bunch of the different things. I've learned so much, even from urologists that send me patients all the time with kids that are bedwetting. And so, so what is epigenetics? When I look at epigenetics, you know, nobody ever talked about that 30 years ago when I was in school. They just said, well, genetics are, you're born with this small mouth and that's how it is. And so if you're born with a small mouth, you need to go take out 4 teeth and make those teeth pretty and give somebody a pretty smile. And when I was treating my patients, and this is this kind of gets to what led me down this path, I would treat patients with crossbites, and then as I expanded them, I'd have these parents come back a month later and they said, wow, you changed my kid. My kid's not snoring anymore. And, you know, I'd have some parents say, hey, my kid was bedwetting before you did this expansion, and now they're not bedwetting. And initially I just kind of blew it off. I was like, okay, that's cool. I'm just straightening teeth and I corrected a crossbite. But what I noticed is when I did expansion on these kids, I quit taking out teeth because I could expand these kids and grow their jaws to the point where they didn't need to have teeth pulled. And when I switched from an extraction orthodontist to a non-extraction orthodontist and a growth and development orthodontist, those stories started happening almost on a daily basis, of these parents coming and saying, hey, you've changed my kid. My kid was on ADHD medicine and now they don't have to be on it. My kid was a C student, now they're a B and an A student. And then I started going, oh, okay, so what am I doing? And I still was, you know, this is a slow process over the years. And so then I said, okay, so how far out into the age groups can I expand patients? And in school, they say, you know, boys, you can, you know, grow them up to about 16 and girls about 14. And I started expanding people at 18 and 19. And one year I had 3 ladies that were 27 years old that I expanded them because I didn't want to take teeth out. And we got sutural splits, and they came back and said, hey, I can breathe better. I'm sleeping better. And so I learned a lot from, and I'll give the credit where the credit's due. I learned a lot from David Singh, taking the Vivos course and learning about epigenetics. And that a lot of times genetically, we're actually programmed to go one route, but we don't get the stimulus to grow that amount or grow that direction. And if you give them that stimulus later on in life, you can still generate bone and grow jaws and change things clear out into your 60s and 70s and 80s. And so when I look at, you know, the methylation of the genome and stimulating stem cells and everything like that. It was interesting. I was sitting in the course with at Vivos, and these guys were talking about stem cells, and I was like, they were talking about the periodontal ligament and everything. I said, you're just talking about undifferentiated mesenchymal cells, right? And they were like, well, yeah, but everybody uses the word stem cells now. And so, and then I have multiple kids that come in genetically identical, and yet they look different because they grow different. And so what I was doing was biomimetics. And what biomimetics is synthetically changing what the stimulus is, and changing the biological process. And then I said, well, how do we use that? Well, in dentistry, dentistry uses biomimetics. If they lose a tooth, they put a bridge on, and they mimic what nature was supposed to have there, and they change it for the health of the patient. And so the different functions in dentistry in biomimetics is restoring function, eliminating disease, and improving aesthetics. And then how do we do that in orthodontics? Same thing, we're restoring function. A lot of times we're restoring function they didn't even realize they had, or creating a better function. And then eliminating disease. And I don't really focus on the improved aesthetics. That's just a given. That happens when you get people's jaws widened and their teeth straight and everything. And so the question is do we have, are we genetically prepositioned or programmed that we're going to just grow a certain way, or is there a lot of nature that works on this? Is it genetics? Is interstitial bone growth a genetic thing, or is it a nature thing? What happens if you put pressure on the bone? You know, as I tell people all the time, you know, and the patients come in and they've got these little kids that are coming in. I said, you know, our brain grows with the pushing of the development of the brain, or our skeleton grows with that. I said, how does our maxilla and this whole area right in here grow? And really it grows by the function of the tongue and the swallowing pattern. And if that is disrupted from even before birth, then you're going to have a different outcome than somebody that functions correctly, even in embryo. And so, so when we look at this and we say, okay, when does the tongue start to form? It starts forming at 4 weeks in embryo. Our palate's at 5 weeks, our mandible at 6 weeks, our maxilla at 7 weeks. So early on in development, all of these, the airway starts to develop. And when does the malocclusion start? Whenever the baby starts to swallow. And so at 20 weeks in embryo, the baby starts to swallow. And every time that baby swallows, that tongue pushes into the palate and gives that stimulus for that maxilla to take off and grow. Well, if that tongue doesn't do its job and can't get up there, then the maxilla doesn't grow. And if the maxilla doesn't grow, then neither does the nasal airway. The same bone, the roof of the mouth, the floor of the nose, the exact same bone. And so having a good functioning tongue from birth or even before birth is so important, and recognizing that. And if somebody has a tongue tie, anterior or posterior tongue tie, and you can fix that at birth, then you're going to have a much better facial growth outcome. And so when we look at the, tongue tone and tongue posture, and the picture on here, somebody that has a low tongue tone, they're going to have that high vault palate. And everybody that I see in orthodontics, people don't come in orthodontics if they have a nice wide jaw and they have all their teeth straight. The people that come in to orthodontics have narrow jaws, crooked teeth, crossbites, and overbites and everything else. I'm having a hard time finding somebody that doesn't have some type of a tongue function problem with all of these patients. So I'm going to skip this because everybody's probably seen this one. I'm going to just go on to the next part. So when you look at the frenum, That's that little folded tissue underneath the tongue, and it restricts the mobility of the tongue and its function. This is just some slides of how everything is. And then why does the tongue tie develop? It's actually part of development. But as the tongue develops, as it develops and comes around and joins in the middle, as it goes through that development, there's supposed to be a process of apoptosis where that tongue tie or that frenum disappears. And, you know, on the majority of the population, it does. But the population that I get to see, there's generally a pretty significant tongue tie that's underneath there. And so if that apoptosis doesn't happen, then the programmed cell death, and then that tongue tie is stronger than what it's supposed to be. And then we'll go on here. In nature, you see this happening where, you know, the frog's supposed to lose its tail and it doesn't. And so, and what is the composition of the tongue tie? It's actually the fascia that holds everything together. It's just, it's thick and it doesn't have much flexibility. It's kind of like a tendon. And everything is connected, you know, from the tongue all the way into our neck muscles and everything. We could go into a whole nother presentation on tongue ties and headaches and everything else that goes in there. You know, what we think of, you know, I think when we were in school, everybody recognizes we had to memorize all these blood vessels and everything. And what we think something is really not what it is. Reality is, when you look on this picture in the bottom down here, that's what the blood supply looks. It's not like the ones that they have in textbooks, and neither is the fascia that connects our tongues. So anyway, this is a good picture of what I see a lot of. I see tons of tongue ties that are coming in here, and they say, what's the purpose of a frenum? I saw this and on the thing, I thought that was kind of cute. I don't know if you guys see this, but I see a lot of this kind of crap in the world. It seems like everybody's decorating their bodies with things. And then there's other tissues that have tethering that, you know, it's interesting to me that in the medical world, if somebody comes in and their fingers are tethered together, there's no problem about going in and fixing it. You know, they'll go through all these surgeries to fix it. And yet in the medical and dental world, there's all these very strong opinions of, well, the tongue tie is normal. Everybody's got one. And even in our community, I have pediatricians that are against fixing a tongue tie. And so I don't know, I get frustrated. This just gives you a little idea of what you can do with pressure over time. That's pretty gross. So as we go through with little kids, you know, if their tongue tie is significant enough and they don't get the stimulus for that tongue to push up in there and develop their maxilla, and then you're going to have a lot of other issues that go along with it. Not just speech issues, but mainly growth and development things. So when do you treat one of these? I treat a lot of babies. We see here in our community anywhere from 1 to 10 babies a week that we fix their tongue ties. And I like to use the CO2 laser. I know there's different methods out there, but the earlier you get it fixed, the better the result will be. I had a really good experience here probably about a year ago. I had a family come in and they had 3 children, and the 2 older children came in with just really, really crooked teeth. And both of them were mouth breathers and they had class 2 bites, and so we did our consultation on them, and then they had this 4-year-old sitting there, and the 4-year-old sat there the whole time, calm, mouth closed. And as we started talking about tongue ties, Mom said, oh, well, yeah, our little 4-year-old here, when she was a baby, we went to this guy named Kotlow back in North Carolina, I think it was. And she says, yeah, and he fixed her tongue tie. I says, can I look at her bite? She had this nice broad bite. She had all these spaces in her teeth, a perfect class 1. And I said, this right here is my proof that if you would have fixed these other 2 kids, because they had tongue ties early, if you would have fixed them at birth, you wouldn't even be here to see me. And by far, that's the best treatment we can ever do, is fix things in the early stages rather than waiting until, now we have to do a lot of fix and repairs on these kids. So these are very common to see, the lip ties and the tongue ties, and a lot of the symptoms that come along with it. Unfortunately, we don't have acceptance in the medical community that, looking at a tongue tie and fixing a tongue tie can help kids sleep and breathe and have everything else develop. They have to have mom have symptoms and baby has symptoms, and it's really the worst of the worst that we actually get to treat. And so when we look at this is a video on the correct, or I'll just play the video here.
In order for effective breastfeeding to occur, a good latch is required between the infant mouth and the breast. An effective latch requires a few things from the infant. The mouth is widely open with lips that are flared or curled out. The tongue is extended over the gum and under the nipple. The nipple needs to be fully inserted into the mouth, including some or all of the areola. If any of these factors are missing, breastfeeding may become ineffective. Symptoms for the mother include prolonged feedings, painful nipples, and decreased milk production, while infants may exhibit noisy suckling and gas pains. A normal infant tongue has good mobility. Tongue tie is when the tongue is stuck to the floor of the mouth, preventing adequate mobility, which leads to an ineffective latch. The tongue tie may also be hidden under the mucosal lining, a condition called posterior tongue tie. With tongue tie, the tongue tip does not extend over the gum, causing the newborn's gum to chew on the nipple during feeding. Also, the up-down motion of the tongue is hindered, preventing an adequate suck, resulting in decreased milk production. A surgical procedure called tongue tie release can easily correct this cause of ineffective breastfeeding. Upper lip tie is when the newborn's upper lip does not curl up or flare out enough, resulting in loss of suction and the nipple to be incompletely engaged within the mouth. A surgical procedure called upper lip tie release can easily correct this cause of ineffective breastfeeding.
All right. So, getting these little babies at the beginning of life and getting them the right start on tongue function is, in my view, what we should be looking at, and instead of trying to treat so many people when they get older, which that's all orthodontists do. If I can treat all these little kids, at birth, then I think that's the way that we need to look at this. But unfortunately, we get a lot of pushback from the medical community and even the dental community on that. I think it's interesting when you look at some of these different pictures of macroglossia and bifid tongue and microglossia, and look at the size down this picture on the bottom down here. When you got somebody that doesn't have, they have microglossia, the arches just don't develop. And the tongue is so important to the development of everything around it. So kind of like what I was saying before, if the tongue is tight and to the bottom of the jaw, and the patient's nasal airway doesn't develop because they didn't get that stimulus, they become a mouth breather. When I look at on the orthodontic side of things, if a kid can't breathe through his nasal passage and they're an obligate mouth breather, what they do is I'll turn like this, they drop their jaw and they're now breathing through their mouth. And as you're going to see here in this next slide, how fast everything grows in the first 5 years of life. The first 5 years of life is our most critical time to treat these little kids. But if you drop your bottom jaw and it's hanging here as an airway, it doesn't get the stimulus to grow forward. And so, you know, you start seeing these little kids that are mouth breathers developing these class 2 bites, you know, as early as 2 years old. You know, the longer they mouth breathe, the bigger the overjet and the overbite is. And so when we look at this slide right here, and we look at the age of the patient and the development of growth of the jaw structure, from 0 to 2, we get almost 50% of our facial growth and development. And you know, that's when the teeth start to develop. That's where airways are growing. And you see these little kids at 2 years old and they're already mouth breathers. I have little babies that come in that are 2 weeks old that are obligate mouth breathers already. And they're severely tongue-tied, and you fix it and within a month they're breathing right. But in orthodontics, in the American Association of Orthodontists, they say, well, wait until you're 7 years old and then go see the orthodontist. Well, the problem is by 7 years old, 80% of your facial growth and development is already there. We've already missed the biggest picture, the biggest opportunity to help these little kids. And so go through these. There's other things when you see with these kids that, you know, if they've got underdeveloped jaws, and I don't know about everybody else, it'd be nice to be in a big room where we could all talk together a little bit more, but how many of these kids come in and have had just chronic ear infections until you treat them? I have tons of them come in, and it's like, you know, on their health history, how many ear infections do you have a year? Oh, my kid has 2 or 3 ear infections a year. You know, a lot of those kids have tubes in their ears. Well, if you have a narrow constricted maxilla, the eustachian tube is kinked and nothing can drain. And so, kind of going through this, if we have these tongue ties, we have high narrow palates, narrow nasal airways, underdeveloped jaws, malocclusions, crooked teeth, and these are just all symptoms of a bad airway. So as we look at these little kids that are developing with these micrognathia or just retrognathic patients, we should never think, oh, this is your parents' fault. There might be part of that, but really it's an airway issue. You see these all the time with the chronic mouth breathers and that just receded chin. Now, I've also seen where little kids compensate and they're still mouth breathers. And what they do is they hold their bottom jaw forward so that they can breathe. And this right here is my little grandson. And when he was a baby and I would sit and hold him in church, he was breathing through his mouth. And I would just take him, and as I was holding him, I'd just take my finger and push his jaw forward. But he always held his jaw forward, even as a baby. And as soon as his mouth closed, he would wake up because he couldn't get enough air through his nasal passage.
Videotape Beckham breathing.
So my granddaughter wanted to be in on this too.
No, Beckham, let me do it.
He had an underbite.
Hello.
No, don't. Let me do it.
But never closed his mouth. And so
He's just brothers. Hello.
but at that little age, he had an underbite.
My hand.
So anyway, I'm pretty proud of my grandkids. The little girl that was talking, her name is Everly, and you're going to see her later in the presentation. We've named our appliance after her because she was the first 3-year-old that I ever treated. You'll see her stuff going on there. But why, I don't know, I seem to get mixed up in my head here, and hopefully everybody's patient with me, but I get really nervous, and I always think you guys all know way more than I do. And so hopefully you'll be okay with me. But I get kind of frustrated with the medical side of things because the only thing they ever focus on is obstructive sleep apnea. And I think that's one little part of the sleep medicine that we look at. I think nasal breathing is the thing that is my mission in life, because if you have them nasal breathing and you have their jaws developing, you're not going to have sleep apnea when you get older. And so it's so important for these, for everybody to breathe through their nose. I mean, it filters the air, it humidifies it. We get the nitric oxide, we get the cardiac problems of patients that breathe through their mouth with, low nitric oxide. And we know that when you're mouth breathing, that, especially at nighttime, that's a sympathetic response. So, and what I've seen is with these little kids, and I used to send a lot of patients to go get their tonsils and adenoids out right off the bat. But now when I'm treating these kids, we very rarely have to send them to get their tonsils and adenoids out. We'll talk about that when we get to Everly. But if you're a mouth breather, you're going to dry out the oral cavity. The air is not humidified, it's not detoxified. I mean, it's not filtered, and your tonsils and adenoids are going to take the brunt of everything. And obviously those guys get bigger. And what I found is by doing the expansion that I do, and they start breathing through their nose, the tonsils and adenoids shrink, and very rarely do we have to get tonsils and adenoids out anymore. I still refer when it's needed, but not as much as I did in the beginning. This is a presentation on TMJ, but it's also talks about it talks about that tongue function. Believe me, I'm going to get to the rhinometer and stuff in a little while, but all this stuff leads up to it and kind of how I ended up there. So,
airway and TMJ. The normal way to breathe is through your nose. As we grow and develop, certain things such as pollen, cow milk, and other variables can cause an allergic reaction, causing the lymphoid tissues known as tonsils and adenoids to become swollen. As the tonsils and adenoids become swollen, they develop into an obstruction for nasal breathing, and slowly mouth breathing begins to be the primary intake of air into the body. In order to breathe through the mouth, the lower jaw comes down, the tongue comes off the palate and settles on the lower teeth. Nasal breathing is the correct way for air to enter the body, and during nasal breathing, the tongue rests at the palate and the pressure of the cheeks is balanced by the tongue. During mouth breathing, the pressure from the cheeks is unopposed by the tongue. The oral system becomes unbalanced and results in the deformation of the upper jaw, creating a V-shaped arch as opposed to a correct U-shaped arch. This also produces an incorrect swallowing function. Upon swallowing, the tongue rests on the lateral teeth, hindering normal tooth eruption, causing a lateral tongue thrust. A constantly open mouth causes the incisors to over-erupt. The result is a deformation of the lower arch known as the bicuspid drop-off. The result of this deformation of the upper and lower arches is the presence of premature contacts upon closing, which shift the lower jaw distally off of the physiologic trajectory. The narrowing of the upper arch pushes the lower jaw back. This forces the TMJ condyle to shift distally while the TMJ disc shifts forward. Upon opening, the disc can shift onto the condyle to restore the TMJ's correct position, reduction of the disc, and then shift back to an incorrect forward position upon closing. This is what causes a reciprocal click. In addition, the muscles could be in a state of hypertonus or spasm, which can result in tension headaches. An incorrect position of the lower jaw can result in parafunctional activity of the muscles, such as clenching and grinding. Over time, grinding can result in severely worn down teeth. As a result, the teeth become even shorter, the lower jaw shifts distally even further, and the vertical of the bite decreases. In time, joint degeneration occurs. The joint becomes deformed, and the ligaments of the joint become damaged. As a result, the TMJ disc can get trapped in front of the condyle. While the click may go away, limited mouth opening will occur. Distally shifted jaw and tongue positions result in even further restriction of the airway. In order to open up the airway, the neck moves forward and the head tilts backwards. This stresses the spine and fatigues the neck muscles, which results in neck, back, and shoulder pain.
Okay.
Airway.
No, stop that. Okay, let's keep going on there. How often do I refer off to the ENT? It's probably the only time I really do that now is when we have tonsils and adenoids that are, class 3, class 4 tonsils and adenoids that, when I take my cephs, there's really no room for those guys to, for the air to get past there. In the past, our tools that we had to determine this stuff was basically a CT scan or a ceph. 9 years ago, well, 8 years ago, it was a year after my heart attack. I had a lot of adults that were coming to me for sleep apnea, and I had been making some makeshift appliances in my lab to just hold their jaws forward. And I went to a sleep group solutions seminar over in Seattle. And when I'm at this presentation, John, I think I saw him in the group here. John's up there talking about how to use the pharyngometer to measure the airway. And he says, yeah, and you use this nasal one to know when to refer to ENTs. And I am the only orthodontist in the group. And I raise my hand and I say, hey, John, I says, can you use this on kids? And honestly, John blew me off. And he says, we're teaching you about adult sleep apnea. And I said, but I have all these kids that I'm treating that are struggling to breathe through their nasal passage. Can you use the rhinometer to measure the size of the nasal airway? He says, well, we don't have any protocols on kids. And he says, I don't know, but I'm here to teach you about how we can correct adult sleep apnea. And so my wife and I went home and I said, I got to buy this. And so I bought my first EchoVision rhinometer and pharyngometer. And I started recording every patient that came through the door, what their rhinometer and their pharyngometer baseline readings were. And then after I did expansion on kids, I would do a follow-up to see what happened. And I will show you, this is a video. This shows you how long it takes to use this machine. And I apologize. I just did this the other night with Anna and one of my staff members. And so it starts out, and if you want to tilt your head, you can see it this way. And then later on, it's going to turn back up and you can see what it is. So anyway, I apologize for my videography. I'm not a professional.
Okay, it's going.
Okay, so I'm going to click on new patient and I'm going to add in the patient's information. I just put first and last name, click save, okay. And then we're going to go to new appointment, initial airway screening. Since we have to calibrate, we put our tube here, start rhinometer and calibrate. Okay, let's see. Let's start with your nasal airway. Nothing goes inside your nose. This tip here is going to rest on the outside of the nostril. You will breathe in and out as normal and easy as possible. And then after a few breaths, now you hold your breath for a few seconds. Okay. And completely hold your breath. Do the same thing on the other side. Check it out. And we'll print down. We'll go to your oral airway test. So we're going to use this mouthpiece. So this part here is going to go inside of your mouth. The tab needs to rest on top of your tongue, and then you will bite down on those two tabs down the side. I'll then have you wrap your lips tight around the outside of this so that only air travels in and out through the tube. And while we're doing the test, you will reach up and plug your nose. All right, so open kind of wide for me. Okay. Okay, got it in there? Okay, all right, reach up and plug your nose there with your left hand. And then you're just gonna do nice, easy breaths in and out through your mouth. I'm gonna stay like that. We're gonna do it one more time. So more breaths in and out. Next breath, remember, you're gonna take a normal breath in, and you are gonna slowly push all of your air out. When you feel like you've let all of your air out, you're gonna keep your nose plugged. Perfect.
Now put both of those together and we'll go over it here. So what this shows on here, the green line is her normal breathing, and the red line is what we call the collapse. And this shows how close the tongue can get. Whoops, I just touched it. It shows how close the tongue can get to the back of the throat. And so that's as easy as the test is. And then I will explain it more, not in the video. Okay, so that took about 3.5 minutes total to get a baseline on any patient. When I started out with this, I bought one, and this was an old green screen. And then I ended up going on eBay and buying 2 more. And then Sleep Group Solutions came out with a Windows-based one. I'm now on my 6th rhinometer and pharyngometer. I have one in each one of my treatment coordinator rooms. And I also have one in my records room so that we can test patients throughout treatment. So anybody that comes in on the child side of things gets a baseline rhinometer and pharyngometer. Actually, under 5 years old, you're not going to get a pharyngometer because their little mouths aren't big enough to get that, but you're going to get the rhinometer, which is really what we're going to be able to change in that 2 to 5 year old range. After that, everybody gets the pharyngometer. And then what we do is in our treatment, we usually will expand for about a month to 2 months, and that 2 months on the little kids, when they come back in for their 2-month appointment, we get a follow-up rhinometer reading to see where we've come with these kids. And we're going to show you some of these cases here today. And for me, it is, I don't know, I guess I like having a report card. I want to know statistically, data-wise, what the end result is. And this helps me understand, did I do enough expansion? And I also have kids that we do expansion and we don't get any change. I mean, I'd like to say that every kid responds and we get awesome results with everybody. But if we don't get great results with somebody, then we say, okay, now why didn't we get good results with this? Is it an allergy thing? Is it a turbinate thing? Is it a polyp thing? Is it, there's so many other things that go on with this. And then, and that's where I involve my ENTs and my primary cares and my allergy people. And, but if you don't have a way of measuring your success and your failures and the amount of change in these kids, you don't know if your treatment is being successful or not. And like I said, it's one thing for parents to come in and say, hey, this is great, my kid's doing better. Well, how much better? Are they at the norm of what they should be? And so here is what we look at with these little kids. There's a cross-sectional part of the rhinometer. And then there's a volumetric size of the rhinometer. And so when a little kid comes in and they're 2 years old, their nasal airway, the cross-sectional nasal airway, should be about 3.2 millimeters. So for you to understand this, that's the size of a coffee straw. Okay, if you look at the cross-sectional view of a coffee straw, it's 3.2 millimeters. And so at 2 years old, a little one can survive on a 3 millimeter airway. But notice that in by 2 to 4, they jump from 3 to 4.5 millimeters. And then by 6, they're up to 4.7, 8, they're up at 5 centimeter or 0.5 centimeters. And, you know, a normal nasal airway for an adult, and we consider anybody that's over 12, consider them, they're like 95% developed. So they should be really close to what an adult nasal airway should be. They should be up at 6 millimeters or 0.6 centimeters. You'll probably notice on here that girls are a little bit more than boys. And I mean, they develop a little bit quicker. I think mentally they're way ahead of us, even as they get older. So on the next slide here, this is our volumetric measurement. And so this is, you know, when you're looking at what the volume of the rhinometer is, that's from the, you know, right where your nose starts back to where your adenoids are. And so that volumetric look in there on an adult, it should be 7 cubic centimeters. That's taking 7 dice and spreading that out through all of the whole nasal passage. And that's what a normal nasal airway is for somebody that's an adult to be able to breathe. Well, we don't expect little kids to have that. You know, they're not fully developed. But what's interesting is by the time they're 4, they should be at 5.1 to 5.5 cubic centimeters through their nasal passage. And most of the orthodontic patients that I have come in are at 2 point something, 3 point something when they come in at 4 years old. And these little kids are just struggling to breathe. And so, and I can share this with everybody so they can see what the numbers are. But this helps me whenever I sit down with a parent and they come in and they sit down and we do this initial screen. And I said, you know, I had a guy that was in here today, and I think he was in his 40s, and we did a rhinometer test, and his one side of his nasal airway was 3.2. I said, well, congratulations, you have a nasal airway of a 2-year-old. And he goes, well, I've never been able to breathe through that side of my nasal passage. And you know, and he says, I've wondered why my whole life why I just struggled. And so he's going into records. We're going to go into treatment. We're going to help him out. Some of the things that you need to look at when you're looking at the nasal airway, a lot of these kids are just full of congestion. Nasal hygiene is huge. There's different things that you can use to help clean out the nasal passage so that they can get an airway. I use the analogy with parents all the time when they come in, the kids are just boogered up. I said, you know, if you throw a bunch of garbage in a garbage can and put the lid on it, and you leave it there for a week, you know, and you have a bunch of rotten food, what's it going to smell like in a week? And they're like, it's going to be really bad. I said, well, take the lid off of it, throw the food in there. You know, what are you going to come back in a week? And I said, all that stuff's going to be shriveled up and it's not going to smell so bad. I said, well, the same thing is if you don't get air going through your nasal passage, it's just like a closed up garbage can in there, and all the tissues and everything like that are going to be inflamed and responding to that. So whatever you can do to get air flowing, the better you'll be. My ENT friends, before they ever do anything, they put patients through a 2-month regimen of Flonase. I send people over to Costco because Costco is cheaper, and they can get 5 bottles of this for about the cost of 1 bottle of Flonase. And what I have them do when they're really constricted and their turbinates are big, they got a lot of inflammation, I'll have them put 1 spray in each nasal passage, and make sure that they snort it through so they can taste it right before they go to bed. And then I want them to do it in the morning before they take off. And they do that for about 2 months. And with that, at least it gets everything flowing so that they can breathe. There's quite a few studies that are out there on whether or not, you know, you want to do expansion and tonsils and adenoids. Like I said, everything's geared around obstructive sleep apnea. And the conclusion of one of these studies is that children with 87% of children with sleep disordered breathing had both treatments of tonsils and adenoids taken out and expansion. 2 of the 16 children underwent just orthodontic treatment alone, but none of the children, they would treat them later on. None of the children just underwent surgery and got the best results. So just taking tonsils and adenoids doesn't open up the airway. And so, and hopefully with Dr. Boyd's help and all the data that we've got, hopefully we can be publishing a lot of the stuff that I have thousands of patients that I've got data on. So hopefully we can take this data and say, okay, this is what happens with expansion versus expansion and taking out tonsils and adenoids. This is my favorite ENT. Get a really good relationship with your ENT. And because even with the stuff that I do, I'm not successful all the time. And I need help from other people, my ENTs and the other medical professionals out there. So this right here is, I don't know, can people see the picture that's on the right side of there? The little expander that's in there? 'Cause
Yes.
most of the pictures that I see of everybody's faces are on it. So this is my granddaughter, Everly. And this is her when she was 3 years old. And my wife and I were actually up at a tongue tie conference in Canada, and we're learning about treating all these little kids. And my daughter calls us on the phone and she says, Everly never sleeps through the night. She struggles to breathe. She's waking up with night terrors. And I told him, I said, I want you to go in and watch her sleep. And so they went in and watched her. And the next night they said, we recorded her stopping breathing for 20, 30, and 40 seconds at a time. And I get emotional when I talk about her because I mean, I have 8 grandkids, and man, you don't want to see any of those little kids struggle. But this was Everly's CT scan. This is her Ceph part of it. And her tonsils were touching the back of her throat. Her adenoids weren't super bad, but they weren't where they should be. And I instantly said, you need to go get her tonsils and adenoids out. And I think this is a big part of her breathing. And this is our CT scan. On here, when you look in their nasal passage, the colors, kids like colors, but the colors tell us how open the nasal airways are. And on a little kid, these should be green. And the color, and at least on my machine that I use, it goes green, yellow, orange, red. And she's orange and red, breathing through her nasal passage. And this is looking in the back of her throat. There's her tonsils. That's a big hourglass view of the back of her throat. And so I definitely wanted her to go get her tonsils and adenoids out. Well, my daughter, she's very bullheaded, like her father. She says, I don't want to do that. I don't want to put my 3-year-old under general anesthesia. She says, can we do anything? And so Everly was my first 3-year-old patient that I put an expander on. And I use fixed expanders. Oh, sheesh. Sorry. Somebody's trying to call me. Oh, shoot. Did it bump off? Are you still on there?
You're good.
Okay, I can't see it. There we go. All right. Sorry, I should have had my phone completely turned off. I'm going to do that real quick. So I have one of my truck drivers trying to call me. I'll just turn it completely off. There we go. All right. So with Everly, you can see the little expander that's in the top of her mouth. Yeah, she has a posterior tongue tie. There we go. This is 2 weeks of expansion. And I think on the previous pictures, you saw the gap that happened in her front teeth. But here's her symptoms before we expanded her and after. Night terrors. We didn't realize that she didn't have a sense of not being able to smell until after we did expansion. And she's grown up with a German Shepherd dog named Aries. And within a month, she started complaining about how bad the dog smelled. Yet she has grown up with him for 3 years and never had smelled her own dog. and she had never slept through the night. She was a bedwetter, and she woke up during, there was multiple times we would go out to lunch with them, and she would fall asleep face in her food, just exhausted. And just after a month of expansion, she would wake up happy. She no longer had night terrors. Her bedwetting corrected on its own. It wasn't something else that happened. It just stopped. When I have a urologist that I'm treating for sleep apnea, and I was telling him my thoughts of why kids were bedwetting, and they were at what we call a PEM, and I was explaining the sympathetic nervous system, the parasympathetic nervous system, and how all of this stuff happens. And he raised his hand. He says, "Man, you got it all wrong." He says, "Think about it this way." He says, "Why do kids bedwet?" He says, if they're not sleeping through the night, and every time that their brain oxygen levels drop, they go from their parasympathetic nervous system to their sympathetic nervous system. And every time that happens, your brain sends a signal to your heart and says, hey, you need to pump more blood up to me because I'm not being oxygenated. He says, what happens when your heart pumps more blood? He says, it pumps more blood everywhere. It pumps it through your kidneys. He says, your kidneys filter more of the blood. You produce more urine, but the difference is he says, rather than waking up, he says, these kids are so exhausted, they're in that twilight sleep. He says, they're trying to stay in that sleep pattern and try and get some sleep that they void themselves. And, I've always thought it was just that parasympathetic, sympathetic thing. He says, but he says, and now he sends me patients. I have 12, 13, 14-year-olds that he sends me patients. I go and expand them in a month. They're done with their bedwetting. The little girl that you saw when I first started off, the pictures of her and her, breathing through her mouth, and then at the end, breathing through her nose. This is her. And so I'm going to just run through some pictures of her. And then we're going to show her rhinometer and her rhinometer readings as we went through treatment. So just when you look at her, she's got this upper jaw that is, all the teeth are pointed in towards her tongue. She's got this narrow palate. You can see that she's got that classic mouth breather profile. When you look at her dentally, she has no room for teeth to develop, no room for these guys to come in. She's going to have a struggle with any of her teeth coming in straight. And so this is her, I think, at about a week into treatment. There's her little gap that she got. There's a couple weeks into treatment. And there's her expander. And then here she is, I think it's about 3 or 4 weeks into treatment. There's where she started out. She had a tongue thrust. I think she also had a thumb habit that went along with it. And when we go to measure the width of her palate, now these are on the primary teeth, and normal width of the palate from the lingual of the 6-year molars on a fully developed person should be about 40 millimeters, 38 to 42 millimeters. So I just average it out and say it's around 40. On primary teeth, when you measure this, you need to add about 5 millimeters to compensate for the width of the arch. And so if you take her basically 26 millimeters, she's at 31 millimeters on the width of her palate. And so she's 9 millimeters deficient on her width, starting off right here, and she's 5 years old. And so right now I know that, that she's going to need probably 2 expanders. Even though you put an 8 millimeter expander in, you get about 5 millimeters of growth. And so because you get some tipping of the molars, and then when you take things off, they come back, about 1.5 millimeters on each side. So you get about 5 millimeters of growth. And so we already know with her that we're going to need to expand her probably 2 times. This is a letter from her dentist that sent her to us, and it's basically, we want you to evaluate her for sleep. The parents would like to not have her tonsils and adenoids taken out. And so, and this right here is my, I hope you guys can all see this. This right here is my pediatric health questionnaire, breathing and habit questionnaire. And when you look at this, occurs 5 to 7 times as a 3. If it's a 2, then it's 2 to 4 times per week. Rarely occurs as 1, no occurrence. And so she snores all the time, interrupted snoring, labored difficult breathing, gasping for air while she sleeps, mouth breathes all the time, even mouth breathes during the day, excessive sweating when sleeping. Most parents are going to put down on the other side, they're going to put down here the difficulty listening and often interrupts. They put that on every kid as a 3. It seems like almost every parent says these kids just don't listen, and they just don't, they're not calm children. And so anyway, we do these. We did her early in 2020, and then we got shut down for a while and we didn't have the data. I've only seen her, well, I saw her a few times in 2020. And then we did a follow-up rhinometer reading on her. But here's her rhinometer measurements. Her minimum when we started is 0.11 centimeters or 1.1 centimeters. She was 1/3 the size of a coffee straw on her right nasal airway. And her left one, she was 0.14. Her volume was 1.7 and 2.0. And so this little girl had no chance of breathing through her nasal passage. This is her after expansion. She went from the 0.1s up to 0.35 and 0.40. And her volumes went up to 5.2 and 5.8 compared to being less than 2. So, I mean, we had easily, I think I've got it right in here. So when we look at what her pre-treatment cross-sectional area and volume was and what her post-expansion was, and then the amount of improvement and the percentage of change, she had like 260% improvement of one nasal airway. And now she can close her mouth and she can breathe through her nose. Going back to where she was not even at the stage of a 2-year-old at 5 years old. And we know that even where we got her to, she's still not at the nasal opening and, cross-sectional area and volumetric measurements as we would expect her to be even as a 6-year-old. So we know there's another expander in there. We'll probably end up doing that around 7 or 8 years old. You can't take a little 3-year-old and you can't expand them 16 millimeters. You can expand them 8 millimeters, but then you've got to give them some time for their body to catch up. What I think is amazing with this is I've wondered, do I need to expand the bottom arch when I'm expanding the top arch? And what I found is you do the upper arch and that bottom arch is just totally dumped in, and then you just let nature take its toll. And probably 80% of the time, by the time 6 months is up, because we leave the little expanders in there for 6 months, their bottom dentition is now matching up with that expanded upper arch. And I didn't even have to put an expander down there. The older you get, the more you have to look at going and expanding that, because nature doesn't help us as much. That first 5 years of life is so critical. So what's next for Everly? And that is we leave the expanders in there for a minimum of 6 months. And when I take the expanders out, then what I do is a lot of times I'll either put a, if they were a kid that had a deep bite and their bottom jaw sits back, I'll put a bite plate in, and I'll put a bite plate with a ramp on it so that when they go to bite down, it slides their bottom jaw forward so that they can naturally just get that bottom jaw to grow forward. Then we reevaluate them every 6 months and we check their airways every 6 months. This right here is my attempt at a quick pulse draw of a bunch of patients that we took their before and after rhinometer readings and their volumetric readings. And the results were that on average, you can see some patients in there that had these massive improvements of their airways, 114% improvement, 42% improvement. Some of them didn't have an improvement. And, looks like patient 14 is Rowan, because those are the same numbers that are there. But if we don't have some way to track these patients, then we don't know if we're really getting our best results. So these are some of the rhinometer and pharyngometer readings that we've seen with other patients. And I don't know if you guys can see them very well. But if you just look at the graphs, the top one is the before and the after is the after treatment. And you can see, and then there's the numbers there that go along with it, of how much improvement we've have on those nasal airways. Like I said, I really like to have a metric and a way of looking at the patients. I'm going to hold something up here to show you guys. I just had a patient that came in today, and I don't know if I can hold it up here and you guys can see good enough on there.
Yeah.
But there's
Dr.
some.
Christensen, do you have more slides? Because if not, you can stop sharing and then we could see that.
No, we do.
Okay.
Yeah, I've got more slides to go on here. But just to give you an idea, and this was a 14-year-old that when he started out, his minimum cross-sectional airway on his nasal passage was 0.39 or 3.9 millimeters and 4.4. After expansion, he went to 7.4 millimeters, which is above normal, and 5.2, which is just barely under normal. His volumetric went from 5.8 to 8.3 cubic centimeters, and on the other one was 3.6 to 6.5. So, I mean, really, really impressive improvements. But the mom was just like, yeah, he quit snoring and he's breathing and he's doing better in school. But I myself am like, I'm data driven. I want to know, okay, how much did we actually get him? Is this kid at a stable point where we don't need to do, any more for his nasal airway, or do we need to refer him to the ENT? And so here's, a bunch more of these rhinometer and rhinometer readings on here. This is an impressive one here, almost down to 0, and then clear up to, 5.2 and 5.8 cubic centimeters. And so what we found is, on average, if you just take everybody, we get about a 41% cross-sectional increase on their nasal airways with expansion, and about a 55 to 56% increase in their volumetric measurements. One of the other things in looking at all of these is, if you have somebody that has one nasal airway that is really low and the other one's not, and you go in and do treatment, what happens is the one that's low gets really better, and the one that was kind of okay doesn't really change a lot. It's like the body just says, hey, this is where I need this growth and development. This is where I need this to happen. And I see that a lot with all of our patients. Those kids that are just super low on one side, you expand them and all of a sudden now they're breathing better. So when we look at other patients, now I've got I got more patients and stuff that I can show, or do we want to just open this up?
Yeah, no, I would love to. You shared so much, and I know people probably have questions about the EchoVision and how you utilize it. Why don't we just open it up and just have a discussion and go from there?
All right.
Why don't you stop sharing, so this way people, you can turn your cameras on, don't be shy, and you can kind of jump right in, or you can chat your questions also. I know Dr. Boyd, I know you had a question. That why don't you kick it off and address any questions you had?
Well, I have 2 questions. One right away is the mouthpiece doesn't fit most little 5-year-olds. So why is having rhinometry and pharyngometry important for adults? But I understand why rhinometry is important for both kids and adults, but why is pharyngometry not important for children? And for me, I just don't understand the correlation. Like, if an adult improves with treatment, do you see an inverse relationship to pharyngometry versus rhinometry, or what's the correlation, and why is it not important for kids if it is for adults? And that's
Well-
just my ignorance. I don't know anything about it.
Okay. Let me tell you what I use the pharyngometer for.
Yeah.
The pharyngometer helps us to understand the, like on the video that we showed of my staff member that, we did that and it showed her collapse of her airway. The pharyngometry for me is more used for obstructive sleep apnea. And the pharyngometer is, it does give us it gives us a baseline of what their oral airway is. With the pharyngometer, they've got airway metrics. There are these jigs that you can put in there, and with the pharyngometer, you can gauge where to make your appliances for people with sleep apnea. And so the little kids from 2 to 6, 7 years old that I'm treating in there, I'm going to treat them the same whether I have the pharyngometer and that treating their airways. And I haven't found that the pharyngometer in the little kids gives me a whole lot of data, as far as measurements and that, because it's really a tool to find the most optimal position, vertically and horizontally when you're making a sleep apnea appliance. And so the appliances that we make, what we do is we dial in with the pharyngometer. We do a baseline of where they started. And then like what Anna did with our other employee there, she had her push all of her air out. And then what you do is you take the jigs and you put the jig in and say you're 1 millimeter vertical and right edge to edge on your bite. And then you have them do that same process where, they're breathing and then they push all of their air out. And what you're trying to find with the pharyngometer is the most ideal position of the jaw to keep that tongue from going back and blocking their airway.
All right, that makes sense. Absolutely, it doesn't seem like it would be practical to do that in kids because we don't have to do those adjustments to,
Right.
Okay, thank you. That's helpful.
Yeah. So, as soon as they're, 6, 7, 8 years old and they've got a mouth big enough for it,
Mhm.
I'm gathering all the data,
Yeah.
but I don't see that that's really a great tool because, when we're looking at little kids, mainly the reason they're mouth breathing is they can't breathe through their nasal passage.
Mhm.
So,
Mhm. Great. Thank you. Great presentation.
Yeah, thank you. Dr. Boyd, can you share why you're so excited about when you first, heard about the rhinometer? And I know you're writing a textbook and a chapter in a textbook. Can you share the value that you feel this has, that you are going to get one in your office?
Yeah, it's absolutely, Bret. The whole thing about a report card is just, even if you have a validated questionnaire, which is more than just subjective information, but it is highly, it's the parent's opinion. They're answering things, but it's meaningful. But this is something hard data, and he used data driven. I'm the same. People want that, and if we're going to get published in top tier journals, and if even our pooled data, are increasing, using Ben's cohort and Bret's cohort and mine and several other, we have got to have standardized tools besides things like questionnaires and looking at radiology reports. All those things are important, but I think this rhinometry thing, this is what is going to tie it all together, and we all have to be doing it the same way. One other observation along that lines is, if you ever had, and I posed this question to you, I don't know if you got to it, but if you ever had a little kid, 3, 4, 5-year-old, that's come to your office for a workup and had rhinometry, and for whatever reason, the pandemic or finances or the people move, but then they come back into your life a couple years later and you have to work them up again, that is a perfect control to see if the rhinometry numbers change with growth instead of treatment. Because everyone asks, well, would those effects have happened regardless? You did your treatment, but maybe the kid was just growing. And we have lots of answers to that now from literature that goes back 100 years. But I wonder if because how long have you been doing rhinometry? And might you have a control, an inadvertent control that a kid never got treatment and you could measure, over a course of time that the rhinometry changed or not, or it didn't?
That's a good question. I have not looked at that because I don't have people that come in and then don't come back. As soon as a parent sees my kid's breathing through something smaller than a coffee straw, and my treatment for these little kids, I should probably charge more, but I charge $1,000 to treat a kid for a year to grow their jaws, and we make it so affordable because and if a parent says, well, I just can't afford it, I look at my staff member and says, then we're treating this kid anyway. Because I can't in my heart let a kid walk out the door and they can't breathe.
Well, sometimes they move away or go on sabbatical. It isn't always something like that. You treat so many kids. I think it's inevitable that there's.
I'll have to ask my staff. That's a good question. I've never had asked me.
Well, we don't have that many either, but they're there. And I think we got to look for them because it's not like we can run a control group because you can't withhold, a therapeutic regimen for the sake of controls. And, so anyway, it's fascinating what you're doing. I'm so pleased to meet you and anxious to learn more about this.
What's interesting is I presented this same lecture at a conference, and the American Association of Orthodontists sent a team in to lecture against me.
Yeah, no, that doesn't surprise me.
And it's interesting, the presenter of this said, I don't know about this whole rhinometry and all this stuff. He says, these little kids that have these constricted airways, by the time they're 15, they've outgrown that.
Yeah, right.
And I raised my hand. I raised my hand. I said, so this little kid can't breathe at 3 and you're going to wait until they're 15 just because you say they're going to outgrow it? What happens to that kid during all those formative years? And they could have had oxygen. They could have been breathing better. And it's simple. Why would you wait all those years just for them to grow out of it? The problem is I am seeing adults that come in with sleep apnea, and the majority of them have constricted nasal airways, underdeveloped jaws, no tongue space. And it's like, okay, so they didn't grow out of it.
You don't need to publicize it, but I sure would love to know the orthodontist that posed the question that way to you, not to trash him. I didn't always know what I know now, but I would love to know who said that. If it's a person of power, that is so sad.
Well, he was the president of the Pacific Coast Society of Orthodontists for the AAO.
Yeah. Well, I'll send him some data.
Can I make a comment on to address a very important part that both Kevin made and you did, Bret? So I'll tell you a quick story. I had a patient that was, as an adult, really bad narrow airway and struggled for years, a lot of physical problems. I'll just cut to the chase. I walked into the office on Saturday and our administrator said, I'm really worried about this guy. He usually texts us to confirm the appointment. I started talking about airway issues with him 4 years ago. I got him to an ENT at Loyola here. He had his airways looked at. He had some major polyps, all the surgery and stuff, but he never addressed as a kid his airway because we didn't know about this back then, which is why it's so important, the work you guys are doing with these little ones. And we looked up the obituaries and we found out that he had passed suddenly at home on September 21st, I believe. He was in my office on September 8th. He had multiple fungal infections on his tongue because he had razor sharp teeth from the malocclusion. And I'm happy to say that at least I was able to get him comfortable working with his ENT where he wasn't cutting his tongue anymore. But the sad part for me is I couldn't save this guy. And I racked my brain over the weekend when I went home that night. I told my wife, I said, I wish I could have done more for this guy. And it was soon after on Monday, I came in with a new focus with the kids. And I saw a child today, a young child that we're starting to evaluate, and I'm treating the older sister. So the work you're doing, Bret and Kevin, all of you guys, with these early interventions with these children are really, really important. And I tell these stories to my patients because the frustrating thing for me is that when I talk to the parents and they think, well, like you said, Kevin, they said, well, he'll just, or I think it was Bret made the point, said the orthodontist push back on you and tell them that these kids are going to outgrow this. They are not going to outgrow it. In the case of my patient, that I had a relationship with this guy for 20 years and he's gone. And it's heartbreaking. So, but I just wanted to make that point of how important I think this is to change the focus of the profession and move the needle in the direction that we all know it has to happen. So I just wanted to share that story. Just somebody that really hit close to home in our practice. And I'm sure, sadly, we're going to see that again with these adults.
I agree with you. I had a very similar experience back in 2019 where I had a guy that walked up to me at a fair. I used to do fair booths and stuff, and I had treated both of his kids with expansion. He walked up to me. He had already had 2 strokes and a heart attack, and he was on medicines, and all his medical doctors had ever done is just prescription after prescription for your high blood pressure and angina and your your gastric reflux and all of these different things. And I said, can you just sit down and let me look at you? He'd had 4 bicuspids taken out. He had the mouth of a 2-year-old. I mean, width of, I think it was 22 millimeters across his between his 6-year molars. And when I said, we need to get you down to the office and we need to start working on this. He died, I think it was 3 weeks later.
Yeah,
and
too late.
Yeah, he was 62 years old.
Yeah.
But he had had all of this stuff. And I said, has anybody ever asked for a sleep study on you? He says, no, I just keep getting prescriptions for all of the problems that I have. And I said, how do you sleep? He says, I've never slept right. And if I was to continue on with my lecture, I've got his pictures and models and stuff, because we got him in for records and then he passed away. So that I feel for you. This is probably the first time in my office, I sat in my office and I just cried and I said, why can I not? I mean, I just lost somebody that I could have helped. But I don't want to ever have that happen on these little kids. I want them to live long and healthy lives.
Yeah, and Dr. Moralia and Dr. Boyd, you are really driving this forward for the general dentist to kind of take over this space. And we're so appreciative of that. I mean, think of all the lives that are changed already, just from the 20 or so doctors that are on here today. We're so grateful for all of you. And here you are, on a Wednesday night at 9:30, still learning more to help your patients. Hopefully this will just get broader and broader and we can really affect the academia, and really with the research, this is what I was so excited about, is if we were to all have this data and pull together. I know, Dr. Boyd, you were saying from your research background, how it'd be great to have a cohort with these numbers that you can publish and really have accurate data using the rhinometer with the children. Dr. Moralia, I wanted your opinion on the data that we saw today. I know you and I met with John at the Greater New York. It seems like a lifetime ago at this point. I think it was 2 years ago, but I know you're on mute. So why don't you come off mute a little bit and just share your thoughts on the presentation tonight?
Yeah, I was so excited to watch this tonight. Thank you very much, Bret, for sharing. We're looking to hear more too. But the rhinometry in the kids should become a standard of care. And so I hope I live long enough to see that become a standard of care, meaning like you would take any other diagnostic that is considered a standard of care today, that rhinometry should be first, because it's a way to track, it's standardized, and you can track your treatment so you know you're making an improvement. And the single most important thing for a child is to be able to breathe through their nose 24 hours a day. And this shouldn't just be a standard of care through dentistry. Can you imagine if the rhinometry was in the pediatrician's office? Now, they might not know what to do to treat, but what if the pediatrician could do that 3-minute exam? And if in a pediatrician's office, they did the rhinometry, and if that child doesn't have the right score, they get sent to the dental or orthodontic practice that treats that. That's the level that this should go to. So yes, I'm hoping that, Kevin, you're going to get Bret into that group that's, making changes, and that the rhinometry becomes a standard of care. It could replace a few things that are considered a standard of care. A lot of people who know me know what I'm talking about. There's a few things out there that are not a standard of care. They're a standard of killing a human, is what I've said in the past. I don't like to hold back, but you have that orthodontist that challenged Bret was absolutely misspeaking and way out of line to say that someone will outgrow it by 15. If children outgrew this by 15, and that was the majority or the normal, then you wouldn't have adults who were struggling. You wouldn't have a continuation of symptoms. You wouldn't have a sleep issue in the society at the level we have it. That is absolute nonsense and misspeaking, and there is no data that shows anybody outgrows underdeveloped jaws or an airway issue or a sleeping issue. There's a lot of data that shows that it gets worse over time. The symptoms increase, they may change. You may have a child who bedwets and they become an adult who doesn't bedwet. That doesn't mean you outgrew bedwetting. You just shifted your symptom. That's all you did. You didn't change your airway compromise. You did not change from unhealthy to healthy. If you don't treat a child who's bedwetting, just because they don't bedwet at 15 doesn't mean they're solved or outgrew it. So you will not be outgrowing any of these symptoms. They just change forms. And the gentleman Bret was mentioning at 62 had a 60-year inflammatory issue thanks to sympathetic drive that collapsed his vessels. And 60 years of that damage is almost unrecoverable. And there's just no reason we should be treating people in their 50s and 60s and 70s when you could have the entire of society be treated between 2 and 10, and you could have this resolved, and it would change the entire face of the medical industry as well, and the entire healthcare compromise that we're seeing throughout society. So I will get behind anything that I can do to help in any way make the rhinometry a standard of care for anybody who's still breathing through their nose. Should have that test done and tracking over time to make sure that we're delivering a result that improves nasal breathing for a child, teen, or an adult. So excited to move forward.
Great, thank you. Well put. Anyone have any questions for anyone? Dr. Christensen, Dr. Boyd, Dr. Moralia? I know we're not a shy group. We've done this before, so.
If I could, on the chat, somebody named Shweta Rodriguez said they can outgrow their malocclusion.
It was a laugh out.
Oh, joking. Oh my God, I thought, I don't mean to call somebody out, but okay. She was joking. I was like,
I'd like to see that.
yeah. Okay, thank you for qualifying.
No problem. If you want to jump in, just come off of mute. We have a lot of like-minded dentists. You can learn a lot from each other.
Hey, Bret, can you just talk a little bit about, releasing a tongue tie on a 2-year-old and how that can change them from mouth breathing to nasal breathing?
I'll be honest with you. I don't do it on 2-year-olds. And the reason for that is I do a lot of tongue tie releases, and I've actually got some videos of doing that in the later part of my presentation. But when I first started releasing tongue ties, I released everybody's tongue ties. I just thought, I'm going to be the tongue tie guy. And the little kids that are under a year, their parents, it's not the tongue tie release that makes things successful. It's the therapy that happens afterwards and that makes it successful. And let me kind of explain that. When a baby comes in, we have the parents do what I call rubs and sweeps and stretches and everything like that on those babies 5 times a day for a month to make sure that tongue heals correctly and functions correctly right after we do it. And I've been able to do that on kids up to, I mean, when they get close to a year, it gets pretty hard because now these little ones have teeth and parents get bit and they don't do the stretches and the rubs and everything to make sure that tongue heals correctly. And I have released tongues on 2 and 3-year-olds and not been successful on that tongue healing correctly. And I've had them, if you can't get that tongue to stretch and have it heal correctly, they can scar back worse and it can be worse. And so what I now do is if they're under a year, then I'll go in and do it as long as the parent commits to making sure that it heals correctly. After that, I jump in and I work on correcting those, correcting the underdevelopment of things, you know, around 2 and 3 years old and up. And then I look at the parents and say, okay, these are all the myofunctional therapy things that you need to do. And by the time they're 4 years old, if a parent really wants it, I require them to go to a myofunctional therapist and have, you know, usually 2 or 3 appointments with them where they're starting to work on all the exercises and the tongue function and the range of mobility and everything like that before I'll ever release it. Because if they're not going to do, and if they're not going to do the myofunctional therapy, then that tongue can scar back and it can actually be worse than releasing it. And so, unfortunately, I haven't seen, you know, I did a whole bunch and I had failures and they said, okay, quit being a failure. So I don't release them until they can, until the kid is cognitively ready to do the myofunctional therapy. I have 8 grandkids. 3 of them were born in 2020, all within 2 months of each other. We fixed every one of their tongue ties. And what's cool, now that they're a year and a half, 2 years old, and their teeth are all coming in, they all have spaces in their teeth. They all breastfed wonderfully. Guess what? None of them have sleeping issues. Yet the other 5 grandkids that I have are all tongue-tied, and all of them had nursing issues. And I have now, those other 5 grandkids, I've expanded all of them. And all of their, and the only one that, the older one that I've fixed the tongue tie, he's 6 years old, but he is one that can follow directions. You know, my 3-year-old grandkids, I love them. They're not going to follow directions. And if you stick your finger in there, they're going to bite you. And so I haven't seen the success on that. Now, Sarush Zagi, he probably has, you know, techniques, because I'm limited on, you know, the technique I use. I use the CO2 laser. I know he does some Z-plasty stuff where he can, you know, and I have not learned that technique. And so maybe, you know, he would be probably the person that's better to treat those little kids at that age.
That makes sense. I mean, I guess I was actually thinking of a 1-year-old, but it makes sense. If you release it, they can posture it up and forward and they can keep it away from the airway, and you know, the rest is history. That's good. Thank you.
Hey, Bret.
Mm-hmm.
I had a question. Roughly, what percentage of children diagnosed with ADHD actually have a underdeveloped, you know, facial structure? And do you see any difference in adults as far as if they're diagnosed with ADHD?
I don't think I have the answer for you on that. As me knowing a statistical, I can't shoot something off the top of my head, so I'm not going to try that. I know that, you know, the patients that I treat, a lot of them come in or diagnosed ADHD, and we treat them, and within a few months of treatment, their parents are now taking them off the medication, and that. And so I don't have any good numbers. Dr. Boyd's probably got better numbers on that stuff than I do.
Yeah, I would say, I was just about to type in the chat that, you know, you can make, you know, this does this and connect dots, but there's nothing that directly that I'm aware of, and I know Karen Bonnick, who Ben knows her work really well, who has done massive studies on massive numbers of kids that, and she's very curious about malocclusion as it might impact attention and IQ and all that, but there's just nothing that directly correlates it. It's sort of like malocclusion definitely correlates with sleep and breathing issues, which definitely correlates with neurocognitive and behavioral issues. But making a jump from malocclusion to neurocognitive and behavior, it's not been done. And I think it's probably territory we should avoid, because we're already, being seen as charlatans because we want to expand 3-year-olds, I just, whatever. It's a good question though. I'm curious about it too.
Was there a second part to your question, Dr. Roos?
Oh yeah, it was the same question. I was trying to see if that could improve anything on adults as well, or young adults. Like I see some patients at the hospital, 22, 23 years old. They have all the signs of what we've learned in Dr. Moralia's course. Moderate tongue tie, narrow arch, can't breathe through their nose, and then they're on Ritalin. And then when I start talking about it, then they look at me like, what are you talking about? You're a dentist, And so I just kind of ease them into, maybe getting an ENT consult and then go from there. And then I look at my assistant, I'm like, there's another Ritalin patient there.
I think the best way that you can walk on, be effective, but walk on the safe side is admit, just say, right, hey, I'm a dentist. And often the things I do as a dentist, because I am within my scope of practice to, diagnose malocclusion. I'm not in my scope of practice to diagnose, apnea or neurobehavior or cognitive problems. But I can say that often when I can resolve the malocclusion, airway components, things will get better. And that often results in mitigation of other things. But that's all. I'm never going to promise anything, but I'm going to fix your malocclusion. You will stay so safe that way, and you'll still be effective. You're not being a coward. You're just, you're putting yourself above valid criticism from people who want us to not succeed. I'm sorry, but, it's like that guy, Bret, that, said, wait till they're 18, they'll grow out of it. Those are people that don't want you to succeed. And it's, it's just the way it is. That's the reality of it.
He's actually an orthodontist that's in my town.
Huh. Well, shame on him. He should open up a book, read some literature from pre-World War II. That's okay. You're on the right side of science.
Any other questions?
I think one of the things that, I know we're talking a lot about the pediatric side of things, but we don't stop at pediatrics. And when I have a patient that walks in the door, I'm checking their nasal airway, and I'll use myself as an example. Years ago, when I opened my practice, across the parking lot from my practice is a Taco John's. And I went over there for lunch every day, and I gained 50 pounds. And when I did gain 50 pounds, my wife sent me to the hospital to have a sleep study done because I woke up gasping for air. And they told me that I had mild obstructive sleep apnea. They did not put me on a CPAP. They said, you're obese, you need to go lose weight. And so I did. I started running, but I'd had a lifetime up until that point of not doing those things. And then when I went into sleep medicine, and when I went to the Vivos course, and I saw that they are growing adult jaws, And I was like, no, we were told in orthodontic school that you can't grow adult jaws. I said, you know what? I lost my 50 pounds. I've retested. I do not have sleep apnea, but I knew that I tossed and turned at nighttime. And I would get up 2 times a night and go to the bathroom. And, being somebody that wasn't in tune with everything, I thought, well, this is what happens. They say on the TV, you got to go buy super beta prostate, and it's your prostates that's the problem. The reason you're getting up and going to the bathroom. And so without having sleep apnea, and I'm treating adults with expansion, I use a Schwartz appliance that I spend 2 years growing adults' jaws. And I have tons of patients that I've grown their jaws 8-9 millimeters. And I've changed their nasal airways, and I've helped them to breathe. And I said, you know what, I'm going to try this. Even though I don't need to, I'm going to see what my patients are going through. And so I treated myself for 1.5 years with expansion, and I grew my upper jaw 8 millimeters. And about 6 months into treating myself, I noticed that I did not get up to go to the bathroom anymore in the middle of the night. And you saw initially, that I do triathlons, and I've done an Ironman and that. And I noticed about 1 year into treating myself that I was biking on these long paths, and I'm pushing at like 18, 19 miles an hour, and my mouth is closed and I'm breathing through my nose. And then I noticed that I'm running, and as I'm running on the flats, my mouth is closed and I'm breathing through my nose. And so, I know we talked about doing the expansion, and there's different modalities in treating adults with expansion and helping them being able to breathe. And it's all correlated. It's not just, hey, let's just take and hold their jaw forward so their tongue doesn't block their airway. If they can't breathe through their nose, they're still going to have sleep apnea. They're still going to have all these problems. They're going to still have all these sympathetic, triggers that are going off. And I think that's one of the things that I get frustrated with a lot of sleep medicine. They just focus on an appliance to hold the bottom jaw forward, and they don't look at the whole system. And taking what I've learned on kids and then saying, oh my gosh, maybe I can change adults. I have hundreds of patients now in Schwartz appliances that I'm growing their maxillas, and I'm opening up their airways, and they're being able to breathe. And there's so many patients that come in that don't have sleep apnea. We do a sleep study, but they say, I am sleeping horribly. I wake up multiple times a night. And we find out they have upper airway resistance syndrome. And you go in and you put them in a Schwartz appliance. Maybe it's not a mandibular advancing, but I think one of the terms that I heard, people have a 2-car tongue and a 1-car garage, and going in and remodeling the garage. And that's what we're doing on these little kids. We're remodeling their garage so their tongue fits in there, and looking at adults the same way and saying, okay, yeah, I can change a little kid in a month. And maybe it takes me 2 years to change an adult, but I still change that adult, and their quality of life has gone from here to here because they're now sleeping with their mouth closed. My wife is a perfect example of upper airway resistance syndrome. We got married. She's had headaches her whole life. And I didn't realize this, but because I'm always off to work and everything, but I knew on Sundays, she's always taking a nap in the middle of the day on Sundays. And so I said, you know what? She's been on migraine medication. She's seen multiple doctors for things. And I said, you know what? Let's do a sleep study on you. And she says, well, I sleep fine. And comes back, she has 27 RDIs an hour. Okay, she has 27 times that she has a respiratory event where her sympathetic nervous system kicks on, and she clenches her teeth and she grinds her teeth. And then I started watching her at nighttime, and about every 2 to 3 minutes, she would be nasal breathing, and then she would 2 or 3 minutes later. So I said, we need to try this on you. I start treating her. She no longer has headaches. She doesn't take migraine medication. She doesn't take naps in the middle of the day. So I think that sleep medicine in the medical profession is they're so focused on the AHI and the apneas that they're missing a huge population of our society that just can't breathe through their nasal passage. And they're struggling with stuff just as much as people that have sleep apnea. So.
And now we have the diagnostics to prove it, right?
Right. Yeah. And
So-
you have a metric, I really thought that I was the only person that was doing this stuff because I live in a town of 30,000 people.
Well, I'm so glad we found you.
It's like,
I think I found them.
No, you did. I did give you credit, Dr.
Thank you.
Province. I did.
I heard you speak, Brett, and I'm like, you have to get into Airway Health Solutions. You have to talk.
Absolutely.
So glad you made it.
But I do want to
That's
take
a quick question.
Yeah,
Real
please.
quick
Go
question.
ahead.
Sorry. Just do you do the rhinometer? Did you do that on yourself and your wife and adults as well? Do you see changes with adults with that?
Yes, absolutely.
Okay, great.
The data that I've got right now, we've been focusing on kids because I think this is where we need to focus on. We need to focus on these kids' airways and when Kevin said, "Hey, I've been asking Sleep Group Solutions, and I know they're part sponsor of this thing, but I've been frustrated with John and Ronnie, and I've been telling those guys for years. I said, you guys are missing the boat. I said, you're using this just to say, okay, refer somebody off to an ENT, and using those metrics to position the mandible. I said, you guys have a tool here that would be, and I think that's how Ronnie makes his money, is selling those things. And I don't get a dime from it, but I'm like, you would sell 100 times more if you could get this into the pediatric community than you do people treating sleep apnea.
Absolutely. Well, I want to thank you so much. Any other questions before? I just want to make sure that Sleep Group Solutions is sponsoring this with, I don't know if anyone needs credits. I know one person who does, but I won't call them out. A lot of you have plenty of CE, but they are generous enough to give 2 free live CEs for tonight. But John, I actually have the flyer on one of my slides. Do you want me to share the screen, or do you want to go ahead?
Sure, we can. Yeah, if you want to, that's fine. I had it pulled up too. I guess I'll start. I'll start with an apology I've been using Echovision, the pharyngometer, rhinometer, and bringing it into dental now for a little over 20 years. And so I'll start with the apology, because you're right. I mean, what Bret just said, we've definitely missed the boat in terms of the what we have with the rhinometer and the pediatric side. The real protocol that we built around the Echovision was for adult, kind of your standard repositioning appliances, all the various devices where you're gonna, bring them down and forward, and using this as a means to predict response to that. And it works extremely well for that. If you make those devices, this is gonna tell you where to put them and where to take your bite, instead of the, using kind of a arbitrary guessing George gauge method. But again, what you presented tonight, Bret, and what you've talked about is kind of totally uncharted. It's not in our manuals. It's not in anything, but it's definitely the future of where we want to go with this. So I'm happy to be part of the group and support and get these systems out there to you guys, because that's really what it's going to take. It's going to take this collective effort and the data that you guys are going to be able to compile to really create that standard that we were talking about. So, I've been working with Lauren for a few weeks to put some pricing and promotion together, really strictly for your group, because this isn't public. It's not available anywhere else. If you go
Don't tell anybody.
Yeah, if you talk to our reps, if you call a rep and say, hey, we want one of those Echovision things, our whole package is $40,000. That's what we typically sell it for. So what we can offer to the group here, I think, is a pretty fantastic deal. I'm happy to I know Jeff shared his information, and I'm happy to share mine. I'll reach out to you guys with your CE stuff anyway, so you have that. If you're interested or have a question, I know, and gosh, I forget who it was now, because Dr. Jacobson, you're on here, and I'm about 20 minutes from you. I live in Gorham, Maine. You're in Capes. You're not very far away. So I saw you reached out on our website like an hour ago. So maybe we can catch up later this week or next week or something, but I'm happy to come over and and meet up and chat or whatever, if you have any questions on the system. So anyway, if I don't know, Lauren, I don't have.
I'm gonna set up a follow-up email, and then I'll have your contact information. This is just, it's here, it's great. I know Dr. Boyd, Dr. Mariah, they're jumping on the bandwagon, and I just wanted to get a good deal for our alumni. So if you want to take advantage of this, this will be the lowest price that they do offer, probably until maybe I'll get them back next year, but this will be the lowest price. And maybe Dr. Christensen, can you share how this has helped you with your return on investment as far as the consults go?
Oh, I wouldn't dare do them without it, because I mean, Anna, who you saw that did the test on Amber in my office, every single person that comes in the pediatric side, she does that. Bridget does it on the adult side. And that's the very first thing that we look at. They come in and I look at it and says, okay, you're not breathing so well. And they like, yeah. And I said, well, here's the data and here's where you should be. I guess I should look and say, what is my acceptance rate on treatment? I don't know what it is, because people just, they get done with the consult and they go right into records.
And they do it.
I don't see, there are a few people that are just about money, and they're out shopping, and those people, it doesn't matter what you do, you're never going to get them. But the majority of people that walk through the door, being able to say, this is where you should be, and this is where you are. And then you sit and talk to them about their symptoms and stuff. And then you say, well, on average, this is what we see with treatment. And, and I use a lot of examples because I have hundreds of patients that I've treated, and I've always got a story about a past patient, of what happens. And, even on the bedwetting stuff, I mean, that's become a big thing. I didn't realize there's so many kids that are out there bedwetting. And I never promise anybody that what I'm going to do is going to cure their bedwetting. I just say, this has worked on this, these different patients. And I said, and you're already underdeveloped. I mean, if it doesn't work, you're going to get a great mouth, you're going to get a great bite. But if it does work, and now we've got, you got a pretty smile, and you've got this, broader smile, and you sleep and breathe better for the rest of your life. I had somebody in today that I was the second opinion, and they went into records. They didn't stop and think about it. They're like, well, we do want straight teeth, but we want to be able to sleep and breathe better. That's more important. And you take the focus off of the teeth with these patients. My focus isn't their pretty smile in the end. My focus is their quality of life. So
wonderful. And I just found that, do you like our new logo? This is the first time we're showcasing it. I'm just like staring at the Airway Health Solutions logo. So that's our 2.0 version. These little things make me so happy. So I just thought I'd share that with you for 2022. So any questions with this, reach out to John, and I'll give you the follow-up information. But Dr. Boyd, how excited are we for this upcoming mini residency? That, I've listened to all of your needs, and I keep getting the feedback that you want to learn how Dr. Boyd does it. It's a technique course. So we're doing the same format like we did with Dr. Moralia, with a 2-day. We're going to actually shoot for live. Let's keep our fingers crossed that everyone's healthy and we can travel April 1st and 2nd in Hollywood, Florida, rather.
Not California. Don't go that way. Yeah.
I know, I always go there, but maybe Florida at the Sleep Group Solutions headquarters. It's going to be a small group. So we're only going to do 20 seats for the live, but it will be virtual. So if you want to save your spot, I highly recommend that you register at our website. You can learn more about the program. And we have an end of the year special, the $300 courtesy off of the live tuition. So we will send you the code for that in a follow-up email. Also maybe on this chat if Gerald, my assistant, can do that.
I don't know if you got it, Lauren, but Darius is committed. So
yes, I did. And
yeah.
tell us a little bit about that. So we have this special guest, Dr. Darius. Tell us a little bit about,
Yeah,
tell us a little bit about what we're in store for.
Darius Lagmani is dual boarded in pediatric and adult sleep. He's also a pediatrician. And he and I have been seeing patients together from first at Children's Memorial Hospital, which is now called Lurie Children's. And he's now head of one of the largest networks of pediatric sleep labs in the country. It spans 3 states. He's responsible for almost 200,000 children. And he feels dentistry he doesn't know how he ever got along without dental support. So he and I have been treating patients together, for over 10 years, and we're now devising courses and working so excited about working with Ben and Airway Health Solutions. We really want to show people what it is that you can do, not just for your own patients as a dentist, but how to communicate with the physician world, the people who have no idea that we can do more than fill teeth. And we've just developed a marvelous working relationship and interactive protocol and a great friendship. And what his portion will do on the second day of our course, our techniques course, is to really show how you can solve so many problems before they really need to get to and there aren't that many board certified pediatric sleep physicians in the country. And there's just not that many sleep labs. So they're really looking to us to solve a lot of the problems before they get so severe that it's really a board certified pediatric sleep medicine physician that needs to be involved. He wants to minimize, and it's just brilliant how he's created these learning networks here in Chicago. And we're training a lot of general dentists in the Chicago area and a few pediatric dentists now. So it'll be a real treat. He's got a lot to offer.
As do you. I know you're being very humble, but I know everyone is really looking forward to learning, how you do what you do, and basically kind of get into your brain for 2 days. So please learn more. Go to our website, and again, if you want to secure your seat for the live, there are 20 seats available. Actually, there are 15 because I had 5 people already reserve, but there'll be plenty of room for the virtual attendance. And we highly recommend, I think most of you have taken our pediatric mini residency, but if you haven't, the Dr. Boyd's mini residency is advanced. So we do highly, highly recommend that you take Dr. Morelia's pediatric mini residency. It's meant to be basically the prequel, if you would, to Dr. Boyd. So with Dr. Boyd, we're going to talk about early childhood, and then we have an advanced mini residency with Dr. Morelia, where we're going to do fixed expansion for teens, for mixed dentition and expansive ortho for teens. So now we have a whole pathway for you guys to really cover all of your bases and really treat from age 0 all the way to 99 with a little bit more tools in your toolbox. So I know many of you have attended this advanced course and have rave reviews. So thank you for that. And again, you can contact me if you want to take the advanced course before June. Contact me and we'll be happy to set up giving you the recording, and then you can also attend in June as well, so you can at least get these skills under your belt.
And Lauren encouraged me to not take Ben's course, but to go through it to see what he does. And I got to tell you, Ben, I mean, today I watched 2 more hours of it. And if you if you can go through Ben's course before you come and hear me, you will be so, your ground will be so fertile. It is going, the compliment, how Ben really sets it up. There's so many things that we share in common. And I just I think Ben teaches, I don't know, 2nd grade through 12th grade, and I'm the preschool teacher. And I don't know, please take Ben's course if you can, because it really will prepare you very well for what it is that I'm going to show you and really treating 2 to 5 year olds. It ain't for everybody. And there's going to be some people that, I think I'd like to do some myobrace 2, 3, 4 years old and then go into the fixed stuff when they're 7 or 8. That's good. But there's going to be some of you that are going to say, you know what, like what Bret was talking tonight, I want to change these little kids' lives even more so. And I want to get really involved. This is all I do now. I've limited my practice to kids under 72 months old. If they're 7, they're geriatric patients and they go to my partners. So that's what we got. But take Ben's course. It's phenomenal.
Thank you.
Can I chime in real quick, Lauren?
Please, absolutely.
So yeah, I've taken Ben's pedo and adult residencies and listened to you, Kevin, many times, and then hearing Bret. And I'll just say it's hard not to want to treat children once you understand this. And a lot of us who have adult practices, our patients have children, and you ask how the children are sleeping, and 5 out of 10 times you'll hear they sleep with their mouth open, and then the bells go off, and you want to help. And if you can't help, if you're not educated with these residencies, it's going to be hard for you to find someone that can help them. So anyway,
No, thank
just
you.
my thoughts on it.
I love the collective. The collective process here. Just the myofunctional therapy course. If you wanted to teach your hygienist how to incorporate myofunctional therapy in your dental practice, that's the course we offer. And we've had really great reviews. Brittany, Sierra, and Carice Laguerre, they're amazing. I know some of you know Brittany already, but they were at the Greater New York Dental Meeting, and Carice I believe she was at the sleep meeting with Steve Carstensen. So they're really industry leaders, and they talk the talk, walk the walk, and they can help you integrate it into your practice. Couple of save the dates for live events. So we know April 1st and 2nd, Dr. Boyd's course, but also July 6th and 9th, we're doing the Dental Festival in Nashville. And it's a great team builder, and we're gearing this towards the doctor and team attending together. July 8th is going to be our Airway Health Solutions Conference. Dr. Boyd will be there, Dr. Moralia, myself, Brittany, Carice, and we really want to get your team on board and enthusiastic about Airway. And the same thing with July 9th is Clear Aligner University, where it's myself and Dr. Moralia and Rachel Smith, really the ins and outs about clear aligners and just using them as an expansive appliance. And I'm super excited because I like to plan ahead, but December 2nd through the 4th of 2022, we're going to be hosting Airway Palooza in Savannah, Georgia. So this is going to be a big event. We're going to have many airway experts and leaders coming to lecture. It's going to be a 2-day first class event. So please save the date for that. And it'll be a great networking event as well. If you haven't already taken the survey to be on the locator, because all of you guys have taken our courses, please do so. Dr. Christensen, you want to add your name to our locator as an honorary alumni? That would be wonderful, so people can find you, okay?
How do I do that?
I know, I think we have a couple of dots there, but please do that. And then this way, it's a referral network we have for each other, but I have so many patients reaching out to me on a daily basis where I try to funnel them to our airway dentists. And most of you are on our Facebook group, but if not, please join because it's really a nice resource and we have some special events there too. So we have upcoming conversations. I haven't worked on the full calendar yet, but January 5th is an overview on airway dentists with Dr. Moralia. So if you have colleagues or associates, this is a very basic course probably for you guys, or if you want a refresher, but please send us dentists who are not familiar with this so we can teach them, the importance of this. And then February 28th, I have on the calendar because it's Heart Month. Dr. Nellie Silva, one of our alumni, she's going to be talking about airway and heart health. But maybe Dr. Christensen will get you on the map too. So that's what we have. This is a great night. I love this format. I wanted to stop to share. I want to thank you all. Dr. Christensen, I really appreciate your time and sharing with us, your personal stories and your journey. And we are so glad that we're all brought together. Thanks again, Dr. Province, for that introduction. And Dr. Boyd and Dr. Moralia, thank you for contributing. John and Dr. Harrison, thank you from Sleep Group Solutions. We really appreciate this, and the CE. And the instructions are easy. You're just going to get your CE certificate email to you from John. So if you have any issues, reach out to me. Just check your spam folder. That'll be in about a week or so. And sign up for Dr. Boyd's course. You're not going to be sorry. And if you haven't taken our pediatric mini residency, we have them in January and March. Dr. Christensen, you want to say anything that maybe you wanted to close out with, or any words of advice for all of our attendees?
My heart's full. I thought I was a man on an island sitting out here, and find out that there's more people that think like me is just refreshing. And it's I'm excited for the future. I'm excited to help however I can. I know what it's done in my practice and the patients that I get to treat, and any way that I can help. I have dentists that come to my office and spend a couple of days. Have had 3 of them in the last month, like from Coeur d'Alene and down in McCall and different places. And, they want to incorporate it, and I'm like, come and just shadow us and see what we do. And then we end up sending them to Sleep Group Solutions to get a rhinometer and pharyngometer. And so, but the more people that we can get involved, the healthier our communities are going to be. That's what I think.
Amen. Okay. Well, John, thanks again for sponsoring this. Tell Ronnie I said thank you. Everyone, it's the great way to end the year. This is our last conversation of the year. So happy holidays, everyone. Happy, healthy new year. I can't wait for some more surprises in 2022, but keep doing what you're doing. We love what you do, and we're here as a support team. So thanks, everyone. Thank you, Dr. Boyd. Thank you, Dr. Moralia. Thank you, Dr.
Thank you, Lauren, for doing such a great job getting us all
Thank
together.
you. It's my pleasure.
Thank you.
You're amazing.
All right,
Thank
good
you,
night,
and good night,
everybody.
everyone. Thanks again,
Good night.
Brett. That was awesome. We're going to do that again.
Thank you. Happy holidays.
Happy holidays, everybody.
See you, Brett. Thank you.
Mhm.